Hello, dear Dr. Suleiman, and all my Indonesian friends. And I'm very, very happy that you are really organizing such a nice conference on cancer pain management. And I'll be very happy to deliver my experiences and share my knowledge and skills with you all. And this is a very pictorial kind of presentation here. And you really come to see so many things which can be done to help these patients who need you in those utmost times. And this is a real human job you're going to do for such patients. You know, when life is limited for such patients, it's more of the quality which they need and more of the living space they need in that very short time what they've got. So that's important to give them a pain-free life, and if they don't survive, a pain-free death. So it's our duty, and human duty and medical duty too. So we know cancer is such a important integrity for many of such people who die at the late age, and with the increasing age expectancy, the chances of having cancer is getting higher. Although we are getting good treatments available, being amongst men or amongst women, that even there are a good number of deaths, which is an it's ever increasing number of deaths in total death number of deaths. But there are cancer survivors which get into another trouble, that is the chemotherapy induced peripheral neuropathies and other such pain syndromes, or post radiation issues or pain which they get day in day out. So we have to really take care of them. They have survived the cancer, but they're dying of the pain now, so it's our duty to help them out. We know it, in all advanced cancer, pain is one of the most important and most ominous and most painful symptom. And I think probably many times all these cancer hospitals are full of those patients who are there only for pain relief. They know they've been a surgery, there have been chemotherapy, radiotherapy, and they know their life is limited and their terminal stages and stage 4 advanced stage of cancer, but they are there just for pain relief, because pain is a pain is a pain. Nobody tolerates pain after all. And it is said, we all must die, but if we can save patients from days of torture, that is what we feel is our great contribution and ever new privilege. The pain is more terrible lot to mankind than death itself. So it's beautifully said in one point of time. In most parts of the world, the majority of cancer patients they present with advanced disease. It's a bad scenario even in the third world countries, all the more so, and where they have a less chances of a cancer diagnosis, early cancer diagnosis and treatment, and that's where we are getting into this trap. And the only realistic treatment option is pain relief and palliative care, and that's a WHO finding. And we are part of the delivering space that we can really do the justice for these patients. Now there are reasons for cancer pain, and that could be a tumor related, the therapy induced, which I told you, chemotherapy, radiotherapy, and even post surgically they have massive big surgeries, and they keep having all those the nerve cut and tissue cut and all those pain procedure coming post surgically, and then can be totally unrelated. We have to take part of this ownership of this pain management for such patients. Now this can be to do with the bone pain, and it can be soft tissue pain, it can be visceral pain, and a neuropathic pain. And we know, as I mentioned earlier, the chemotherapy pain or chemotherapy induced peripheral neuropathy or radiation neuropathies, they have to be treated pharmacologically in their own right. But there are scenarios where you can do some ablation techniques and we can help them out. WHO has defined a ladder for pain relief, and we normally go in chronic pain scenario by such a ladder. But that's not the case in cancer. Here we just don't go by ladder, we go by escalator, and we go on higher modality of pain management, because many times, in spite of best of the pain treatment tried conservatively, they don't get a good relief, and they get into analgesic nephropathies, GI bleeds, or even narcotics which really get into their heads. And I've seen in hospital and ICU settings in cancer hospitals, patients are put in fentanyl infusions or sedative infusions, and they are cut off from the family and life, and that's the worst thing. They die before the actual death. So just sympathy is not enough. We have to be proactive in our management, and yes, believe me, we can really do a lot of good for these patients. Now, I told you, we instead of going through the whole cocktail of this ladder, we straight away go on the higher mode of treatment, and that is what it is. Interventional pain management is doing justice for such patients, and let's see how we can deliver it and how we can do it. And it's a real story. Until you know it, until you know the skills of doing it, how can you deliver it? So first you know it, and then you start learning these techniques and start delivering, and it's very, very helping for such patients. There are few strategies. Treat pain early to prevent morbidity. Use adjuvants, procedures, physical medicine techniques, and early to avoid morbidity and transition into chronic pain. Don't let them get into chronic pain scenario if they're going to survive for longer. Adopt chronic pain treatment strategies early in the cycle and consider interventions. The fourth step, we have to start it earlier, not to delay too long. And no rules exist for the timing of intervention procedures. It's your call in such patients. Please, if a patient comes to me at the last stage and is only a month left and patient is agonizing pain, it's my duty not to go by letter, straight away go for the right procedure for such patient, which can give them the best relief possible. The outcome, what we have to decide, what is the right thing to do, and doing a right thing and right way. And we always try to expect the right outcome. But we have to be more neurodestructive, more in the intervention, more in the neurolysis point of view than just one of those pulse RF and other things. We have to going higher for higher modalities. We know there is a expectancy is less, so we're not worried on that account. Sometimes patients already bedridden, so we are not too worried about going for higher interventions. But pain relief is more vital for such patients. Always guide the block. Don't do those blind things now. We have such a good modality, like we have an ultrasound now available, CM available. Landmark is is in a backdrop. We used to do it long back, but that's not the case now. And to have the best result and the most accurate result with the least of complication, we should rather be guiding the blocks. There are some regional blocks. We can talk it out through my lecture. That's the trigeminal cranial neurolysis, stellate ganglion, or lumbar sympathetic for that matter, for all those sympathetic mediated or maintained pains, or all those dystrophies which they get developed over a period of time. The brachial plexus block are there, interpleural analgesias, parietal blocks. In now erectus spinae pain block is already there. Intercostal root neurolysis we can do. Celiac plexus and splanchnic blocks are there. We may be RF, maybe it is the neurolytic blocks we're talking. And hypogastric or impar block is there for perineal and pelvic pains. And then epidural or intrathecal catheters or neurolysis, we talk it out. And then transvenous pituitary neuroablation, we call it chemical hypostectomy. Now there have been times where you do neurodestructive surgeries. There have been times neurosurgeons used to do it, but it's now less and less required because got a very good interventions modalities are there, which has replaced those higher surgical scenarios. And they used to be like, I told you hypophyseectomy, which I'm going to show you, the chemical one, not the surgical ones. Thalamotomies were there, tracheotomies used to be there, the pontine tracheotomies used to be there. Now we have a dorsal entry root zone, ablations is there, the percutaneous cordotomy, especially in cervical, I told you. And then ventral horn is there, which is commissurotomies are there. So you can really cut off the pain signals by cutting these tracks, and patients pain free. Although there are some comorbidities or some complications, collateral damage, which one really has to be very aware of and minimize as far as possible. Now C1 C2 percutaneous cordotomy is another good procedure. You can really take care of one of the body, pain is totally taken care of. So but yes, it has to be expertise and it has to be done only in expert hands. Like look at this patient. Patient came to my OPD and she was only 33-year age girl with a CA breast, and which she got a lumpectomy done, and then she developed advanced cancer later on at the breast site, and as well as all those mats in the liver, and she was having a pain around. Liver is one of the place where it really takes a lot of toll on liver, and lung takes a lot of toll, and especially the bones also, toll of the metastasis, and you really have to do justice for such patients. And celiac plexus is a wonderful procedure for such patients. I want each and every pain specialist to learn it, do it effectively, and to help these patients. And be it splanchnic or celiac or combo, you have to take a call on that. We'll discuss it. This really helps the patients who's got a pain right from gastroesophageal junction up to the splenic flexure of the large colon. So whole of the gut, small, large gut, and other liver, gallbladder, and all this, and pancreas for the matter, are being taken care of by just one block. And this is there are few techniques, intricacies to that, and must know it. We have a retrocrural block, we have ventricrural block, and then we have the paraspinal block, which we normally do it, and we can do a transdiscal also. And then again, the best part is the transaortic block. There are new things which has come in, and I explain it. But if you look at this picture, this is celiac trunk, and this is superior mesenteric artery. And when you look at the celiac trunk, you have to take care of the 3/4 of the quadrant around the celiac trunk for it to be effective. If you've done 2 quadrants of the 4, it will fall apart. So it is important that you do a due volume, so that that's why you depend on the volume. But if you are very accurate in the transaortic or pre-aortic, then you really can do with the lower volumes. About 15 ml even is good, more than enough. And if you're doing ultrasound guided, you can see it as well. So we are going in the paraspinal in the oblique view, transdiscal by the way, and you can do even I told you the paraspinal also. And then you go just inside, go anterior to the vertebral body, and this is retrocrural. But if you keep going interiorly, now this is a transdiscal approach you're seeing, it's very much on. If you keep going further on, you can see your needle can cross, and maybe there's aorta. If you can do through aorta, it's always good to go transaortic. Once you're getting into the aorta, your needle will give some pulsations to begin with, and if you take the stellate out, it'll start bleeding. So it's good to have look at this bleed, because you're inside the aorta now. Cross it and go anterior to the aorta, the bleeding stops. Now once you're anterior to aorta, once the bleeding spot stops from the needle hub, this is the time you put in a dye, check the dye, and put your neurolytic agent. And a lower volume even is good enough for such patients, but you should really know the spread is nicely spread all over. So you can put in this little dye even in the neurolytic agent and really check the dye spread along with that. Well, I've been doing initially in CT guided also in such patients, and found a very good results. But the radiation is an issue, but if you can manage to, wonderful. I've seen in Hopkins they have got a fluoro CT also. You can really check it while you're doing the procedure. And this is how I do a multi-firing. So what I do is I put my needles inside the CM room. I put 3-4 needles around, 2 splanchnic and 2 celiac, go ahead of the aorta, and put my dye initially first. And once I'm satisfied with my dye in one shot of the CT, I put in my drug in there, and the patient's happy, I'm happy. And you just see one of these needles is going transaortic. Now once you've gone there, you have won the battle, and the patient is fine thereafter. And they got years of relief if they survive of the cancer. Like in chronic pancreatitis, I've done in few patients, and they don't bother because of the pain, which is a very nasty scenario otherwise. Ultrasound is come very helpful in such patients, and you do just have a look at this seagull appearance, beautiful seagull appearance, and you put your needle across, and you can make a needle navigate inside, and you put your neurolytic agent inside, and you can really do the celiac ganglion block. Very effective technique, especially in thinner patients and morbid patients who are in a cancer scenario. They are early cachectic, lost a lot of weight, so it's a very easy procedure if you're going for anteriorly. Same goes for hypogastric plexus block also. I'll show you that. Now, what all agents you can use? You can use alcohol, phenol. These are good neurolytic agents, but you really have to know these few points in there, and what concentration you use, what volume you're going to use. Is going to be a painful, like alcohol is a normally very painful injection, so we tend to give an LA, the pre-treat with LA and then give alcohol, although this pain is only half or 1 minute, not much, but then it goes away. So it's a very good alcohol neurolysis lasts longer than the phenol ones. Phenol has got a little issue with the vessels if it is close to vessels, so it causes thrombogenic effect is there. So these are few important points, but phenol injections are painless by the way, and it's got a double effect, in the sense biphasic effect. First is the LA effect, and then is the neurolytic effect. So these drugs at a lower concentration they are LA, and a little higher concentration they start getting into the sensory and then into motor effect, and that you tend to see. So this is all. I do dilute them sometime with the I told you the omnipec dye, and do see the flow. Remember, alcohol is hyperbaric and phenol is hyperbaric. You can mix phenol with glycerin also sometime, and then because further hyperbaric. So these things can be made use of intelligently and give relief to such patients. Alcohol, I told you, 50% or less is only for 33% is only LA. Over 33% it only does neurolysis of C fibers. 75% it becomes sensory and C fibers, and over and above it becomes motor, sensory and sympathetic fibers. Phenol is less than 3% is only LA kind of effect, 3 to 5% sensory and some motor, and more than 6% is purely motor. So these differential blocks can be made use of in all your clinical practice when you're trying to give a sensory or motor relief for such patient, especially with the mixed nerves. In pelvic malignancies, suprahypoplastic plexus block is a good tool, And this is seen that you just do again paradiscal or transdiscal, and you can just go anterior to the L5S1 disc space where, and especially left of the midline, because aorta is left of the midline and hypoglossal plexus lie next to the aorta, and you just take your needle in there. And what I do is, if I go in transdiscal, I use bend needle inside. I navigate my needle inside the disc to bend onto the right and left and do my drug deposition there after checking the dye. So this is doable. I think you have to improvise things, and it really gives a good result in such patients. So this is just to give an idea. Now lately many people are doing it with the ultrasound guided from the anterior approach. Pretty much fine. In a thin build patient, I have seen many times it's just centimeter true or maybe an inch in total. The needle has to walk this much distance only. Use a thin needle, just go and hit at the L5 vertebral body anterior at the lower edge the L5 vertebral body, which is L5S1 disc space. And actually speaking, you can see all these discs. If you just go longitudinally across, and you can see all vertebra disc, and you come at L5 lower edge and you put your needle there and hit the vertebral body and do your drug deposition, and you can really see the volume going across, and you are not worried about the vessels already gone at the L4 vertebral body. So L5 is pretty much safe, and you put your drug in there and gives good relief. So the use neurolytic if in a cancer patients. You don't have to use LA. Many time you decide whether you want to do a tele test block or you want to go straight over neurolysis. I don't mind if you are sure of your technique and your the place of the putting the drug and your diagnosis. The results are pretty much very good, and sometimes it is good enough. One injection is good enough for patient lifetime. What is required, the short lifetime patient has got. In perennial malignancies, you can use ganglion impart block. It's pretty much good and very, very helpful. Vulval malignancies, anal malignancies, and it's pretty much helpful. And then you use a neurolytic block. You can use RF in all these scenarios, Plancknick, other places, you can use RF, and I do RF and neurolytic both. So to get the maximum relief for such patients, I just don't go by those protocols, RF only or neurolytic only. I combo these things. So you can put your needle in there at the impar, and then you sometimes is a pudendal neuralgia, so you can do a pudendal block. There you have to be careful. Unilateral you can do a neurolytic block or RF, but bilateral you don't do it because sphincters are there with the pudendal. It helps the sphincters part. Now let's talk about different area. Orofacial malignancies, and this patient has got a CA tongue or base of the tongue, and it came long back 2006. So that time we used to do glycerol. Put needle in there, check it, the CSF coming, and you put in the glycerol and make the patient position according to the route involved, V1, V2 or V3. Same thing you can do if with the same needle, and if it's using alcohol, we have a different needle position, or the needle position as well as the patient position when you inject alcohol, because alcohol is hyperbaric, always remember, and the phenol and glycerol for that matter is really hyperbaric. But remember, you may have to make this patient sit in the same position for next 2 hours, and you don't let it spill. I remember one patient is spilled, and a spilled line went onto the vestibulocochlear apparatus, and patient had a bad nystagmus and bad vertigo, and which was difficult to manage. Well, this is the needle position for our usual RF techniques. RF is definitely on for such patient, depending on where exactly is the lesion. It's a V1 lesion, V2 or V3 space lesion, and you know it, and you can put a needle in there and do your RF. Like this patient, it's a pan, it's V2 and V3 both. Just put a needle in there, and the procedure is beautifully done, and patient got a relief, for rest of his life. Like this patient, he has been, now many of these patients have been surgery, they have been in chemotherapies and all those on these radiotherapies, and everything has been done, and they are in pain. Now this patient used to have a lancinating pain, and he had a large tumor which was bothering his glossopharyngeal nerve area, and more so because he's already been operated, so that adds to the trouble. So that time you put your needle in there, and you go to the styloid process in there, and you go just behind styloid process another few millimeters, and now we do a stim. Now we do a RF, do a stim, check with the stim if it's same concordant pain, and do your needful. You can do a RF, low temperature, but yes, and you can always, I do sometime a half ml of a neurolytic agent if I have to. And unilateral is okay, because you can't do bilateral because your deglutition is carried by the glossopharyngeal, so that one has to be careful. And be careful when you do these procedures. Patient sometimes gets a change in the pulse rate and all. Put a hand on the pulse. Done rightly, this is what at the end result. Patients all fine, lying comfortably, pain free, and that is what you really want to give them. That's your intent actually. Look at this lady. This is not a real face. This is a deformed face because of the terminal malignancy she's got in that area, and none other procedure is giving her the best relief than a C2 block. So I'm going in there with the needle, do a test block if you want. Otherwise, I do these days put my RF needle in there, do test for the pain response when you do a stimulation, and then I do a RF, and way out I do a neurolytic agent also. But be very very careful. You are very close to brainstem now, and your all actions are in millimeter spaces, so one has to be very guarded when you're doing this procedure. But yes, done rightly, they're wonderful wonderful procedures. Something same thing like we do for headache. We do a C2 block so for headache, but that's a little more safe. But here is a cancer patient where you want to go higher with the intervention, and that is what gives the best result. You cannot be too cozy and too kind of a fear complex, and you deliver the response. You have to be a little more proactive, but know your job well and deliver it well. Sometime it's a radicular pain in some patients, in especially plexus areas. There you can do a pulse RF or a little low temperature RF, and can give some relief for such patients. Then sometimes there are such scenarios. One has to be careful. Now this patient, look, little boy, and he's got a neuroblastoma and is such painful. So it's a 5-year-old boy only, and he was in a big pain. Look how the weight loss he's got. So you can put in those tunnel catheters, epidural or spinal for that matter, and you can manage with the Baxter pumps or flexometric pumps for next few months to come. I have done this for 4 months in few patients. So put in a tunnel catheter and leave with the pump there, and pump can be refilled, and pump can be made use of SOS basis. It doesn't have to be continuous pump. You can always on and off the pump, or on patient demand you can do it. But they have got a very very good response because you do all those combo of drugs, and they really make solace for such patients. Like one such example is a CA breast patient, or any place or pancreas tumor where there's a you can really manage the nerve. You get the plexus where you can put a catheter in there, and you put those catheters and you put your pumps there and give them pain relief. So the opioid agents can be used like morphine, hydromorphone, fentanyl, mepridine, methadone, and then you have to really compare. And there are new drugs which are coming, so fentanyl, other drugs which are already there, so they can be made use of. The non-opioid ones are there, and obviously the LA is the mainstay there. And then you have clonidine is another one which is very good for neuropathic pain, and ziconotide which is there. It's a very good and but expensive one. It's not available around. And then you have all those NMD antagonists like ketamine. I've done with the neostigmine, other drugs also, and even for midazolam, and they can be made use of. And all those GABA agonists and all those drugs can be made use of, which I told you right now, neostigmine and all. And they give a good relief for such patients. You can put epidurally or even intrathecally, and response is normally, I think probably you have to try all modalities what you have with you, but efficiently and safely, and give them a pain relief. I think you're doing a job well that way. The sympathectomy in all RSDs, or where you have all the sympathetic mediated or maintained pain, and more so after surgery or chemotherapy or radiotherapy, it evolves. Here is something you can really help those patients. Or for some reason, if there is vascularity compromise, you can do these blocks to give them a little better vascularity. So be it a stellate block or this block, and you can do it RF, or even neurotic blocks can be done. Stellate, remember, you can't do bilateral, you can do unilateral neurotic if you have to, and but carefully. And then the hormone dependent cancers like breast or prostate, advanced prostate, hormone dependent only, or for that matter widespread neural metastasis all through the spinal cord. There is another very good modality which otherwise don't respond well, is the transphenidal pituitary neuroablation, or we call it a chemical hyposectomy. You put a needle in there and get into the pituitary, transnasal, transphenidal, and I used to do it. Now lately I'm not doing that often because somebody else is taking care of the cancer part, but yes, I used to do it. and only in advanced cases I go and help these patients because it's a little high end procedure. And they say if once you put your neurolytic agent alcohol, it takes care of the pituitary hypophysis excess, and that is where it blocks the nerve. So you are putting a drug next to the periaqueductal gray pain centers, which are the headquarters of the pain in the brain, and it blocks that, and that is taken care of. So you have bombarded the headquarters, for that matter, pain headquarters, and that is how it is going. As you just see needle going transnasal, transsphenoidal, and getting into the pituitary fossa, the sella turcica, and getting right there anterior to posterior clinoid, and you put a needle, bend my needle in there. I go coaxial needle technique and do my pituitary alcohol ablation, and this is when you're doing this procedure with the insulin syringe and 1 ml syringe, you can call it, and aliquots of 0.1 0.2 ml each time. You can go 1.5 ml, and you can really ablate the thing, and you keep looking at the pupils here so that it's not spilling onto the optic nerve. But yes, good procedure. I used to get good response in very bad patients, and lately it's not all that required. No, this is the known. After liver and lung, the another place where they very match very common is the bone. And what means spine has got 33 bones, vertebrae and all this pelvis and other things, other bones are there. So it's skeletal mats is a hell, it's a painful thing. It is there. You do all those biopsies and to make it sure, do PET scans and all those bone scans to be sure of. And I've seen many times the biopsies rarely prove the diagnosis in such patients. Sometimes you have only secondaries, you don't have primary, so that gives you a clue for the primary. You have all those bone metastasis medications which you can really, chemotherapy agents you can give them, and always strengthen their bone with all these drugs along with the zoledronic and the denosumab and other drugs which already come in there. And this is must be done on regular basis so the bones are strengthened enough. New thing which is there, new baby which is there, which is very good, is the basivertebral nerve ablation. And any pain which is inside a vertebral mass, bone mass, you can really take care with the BVNA, because you actually block the nerve which is getting into this area, and that is helpful even in the modic changes, end plate changes these days, where there's this spine pain is either because of annulogenic or because of the end plate pain, vertebrogenic. There's nothing like disc pain per se. And another such patient who's got a CA with the pain and a mass effect is there, I've evolved a technique of mine, put my needles in there, and I've got a plasma cautery which is with a cannon which has got a flexible tip in ahead of that, and I use that flexible tip inside, navigate inside, and keep burning. It really takes the tumor off like anything. It just evaporates the tumor. So debulk the tumor. Once the tumor is nicely debulked, you have a space now, put your cement in there, and you know my technique, special technique of epidural balloon, safety balloon, and that will help these patients. Post procedure, patients walking comfortable, pain free, smiling. Another such patient where there is a MATS is already there, and there's epidural compromise which has started coming in, and the same technique which I told you in that patient, same thing I evolve. I go in there, do my intra-bony work in here with the epidural safety in there, because if I keep doing only intraosseous work, the cement will try to bulge more, and especially in cancer scenarios, they do more compromise, and the iatrogenic cord damage is there. So that safety balloon helps these patients. You put in there, do a myelogram and or the epidurogram, and patient is really happy. And you are happy, at least you delivered cement without any collateral damage. Like look at this patient. He's got a 6 level from D4 to L4, 6 level vertebral collapse, multiple myeloma, and at 3 levels you don't see bone at all. Look at this, there's no bone at all. And all these places I do kyphon for that matter. I did 4 kyphoplasty for such patients, and 2 level I do a cementing only. This level as another level I did only a vertebroplasty because kyphon was not required. And you can really do multiple one in one go, one time if you're proficient, which I do it often. And look at the patient. As soon as patient was back on the trolley, and patient so smiling and happy. That's what you really want for such patients. You give them happiness from all those sorrows and sufferings. Another patient, 4 level of the vertebral mats there you can see, and 2 level to both pelvises are there are bony cysts which are there. So I did 4 level of these cementings, and the pelvic cyst which is painful, very large cyst, painful and very dangerous, so that it may fracture if one weight loading. So I did this 4 level of the cementing and the 2 level of the cementing at the, the pelvis area also, or the ilium and sacral areas. Another such patient who's got a, by the way, they didn't know what exactly is the problem, but on first look of it, there is a clear cut fracture and collapse, looked to be metastatic, but 2 biopsies done previously didn't prove anything. The patient was sent to me by oncologist to help this patient out. I said, okay, I can at least stabilize the fracture. We don't know the diagnosis, but at least I know what I have to do for palliation. So I went inside, I did a biopsy first, and after biopsy, I just put in a cement. Then look at this. I just went from, just like we do a BMAC technique, like, and then went inside and right up to the acetabulum. Look at this. I put the balloon in there. I inflated the acetabulum area because there was a real fracture in there and there was no cavity. If I start putting cement in there, it will leak in first go. So at least have a cavity in there in place now, right over the acetabulum. I put my cement right from this place, and I have reinforced the pelvis just over the hip. Now his patient is able to walk around, can get up and all. And the biopsy came out to be adenocarcinoma. So that is where you really come to know it is a malignancy. Otherwise, before that, it was not known. So they could start some chemotherapy, and patient is some better now. There have been times long back, 2006-7, patient had a CA lung, was sent to me for pain. So I was trying to do pain work, like I did intercostal, then paravertebral, then epidural, then intrathecal at the end, and it was progressive tumor. So ultimately I did a cementing also in this patient in 2007. This is 2007 stuff. So what I do in such scenarios, when there's a torso malignancy, I just go inside, put my needle in their LP, and do my alcohol ablation of the intrathecal. And this is very, very technical thing. Must learn it, do it. There's a lot of chances of collateral damage if it's not done rightly. But believe me, if done rightly, it's a wonderful technique and gives a very instant and lasting relief for many such patients, and especially in the torso malignancies. Any from D2 or T2 to T11 is pretty much safe, but you don't go above or below, because then plexus comes, then you can lose the limb functions. So that one has to be careful with. And like this is what it is when you're trying to put in the alcohol or phenol in this intrathecal space. These are the fibrils, you can say, neurofibers, and these are the ones, they are unmyelinated ones, and they are neuralized, so the pain is taken care of. If you're using alcohol, which is better by the way, and you do a semi-prone position for such patients, put needle in there, alcohol as soon as you put in there, it will float up and it go on to the dorsal horn and dorsal fibers. That's you really looking for, because you want a sensory analgesia. But sometimes it is done for motor, it's the other way around, you want it onto the ventral horn, like spastic disease. But we don't try it, we are here for pain, so I'm trying to should give you the idea. So remember, now this patient again has to be in the same position for an hour or so, because then only the sensory fibers are taken care. But if it is a phenol or some other drug which is hyperbaric, then you do a semi-supine position, put a needle in there and let it fall down and get onto the sensory part there in the dorsal horn there, and that's a hyperbaric one. So this is important what position you maintain, but keep in the same position for next hour or two. Now just give an idea. I put my needle there, it is there's a stent there and all those surgeries been done, see a lung, and you put a needle there intrathecally, go in there, and my needle is on this side. When I put my dye, remember, my dye is hyperbaric. My dye will fall to the other side, but my alcohol will come on the side of the needle. Keep that in mind. So it is not the dye which is indicated. Dye just to know that you are well intrathecal. That's the only reason you put in a dye, to be sure of. And then you put your alcohol. Alcohol will be going the other side than the dye, and that is the indicator. That's very, very helpful for such patients. There will be a transient pain, very severe pain. So you might give a light of short GA or some drug, or ask patient to cooperate and do a smaller aliquots again. Very, very small, 0.1 aliquots. At one segment, you can put about 1.5 ml of the alcohol. So if you have 2-3 segments which you have to take care of, put it in the central segment, and then you make a patient the head up or head down 10 bug or anti-10 bug position to really understand the hyperbaric part will be floating up, and you can take care of 2 3 4 segments on this side or that side. So please be careful on that account, because it may go to the place where you don't want it to be. So one has to be very careful, cognizant of this fact that it can travel inside, walk inside, hyperbaric or hypobaric. Now about the paravertebral, another very good block, very effective block, safer rather for that matter, and good for unilateral pains, is you go inside, put your needle right on the TP and walk up or walk below caudally or cranially, and then you are in the paravertebral space. Now the best thing is, you've been doing fluoro guided very often. The ultrasound is beautiful, very very helpful tool. You have this nice triangle which is there. You can put your needle in there and put your drug in there. The lung will push back, push down. The pleura will be pushed down. You will know you're in paravertebral space, and you can do the paravertebral block. In a bad scenario, cancer, you do a segmental paravertebral neurolysis also if you really want to. But keeping in mind the paravertebral space and the abdominal space, they are communicate with each other. So one has to be careful that when doing this, what volume you're going to use, and keep watching, keep asking patient about the distal aspect, limb or distal part of the body. Please ask these patients all these facts. Now this is another patient where you put in interpleural catheter. The same lady which had a CA breast with the all livers involved, and the thoracic cage was very very painful. This is another modality which I did long back. Interpleural catheter, just like epidural catheter, put in catheter, you can put in a large volume of the neurolytic agents in there, hyperbaric or hypobaric depending upon, and accordingly you position this patient. The pleura is a large space. You can take care of the apex of the lung up to the diaphragmatic issues which are there, and it gives relief to such patients. But anyway, when you're doing all this, must remember that when with the given life, she's only young, 33-year-aged lady. Look at this smiling thing with the baby in lap, and it's 2006 I'm talking. But well, you have to give them a relief because she was howling in pain. So not great idea. And one has to really give relief for patients. You can't be a bystander, and you have to come proactive, go with the helping hand for such patients and do a pain relief. Don't give up at all, because these are difficult case scenarios. I know you need an expertise, knowledge wise, skill wise, and over and above the courage wise to go and help such patients. But believe me, done rightly is very very satisfying, very gratifying when you give relief to such patients, and they're very very thankful to you. Even families are thankful to you. I keep getting those thanks messages from all the relatives later on that somebody died peacefully. And it's not good that somebody's gone, but at least somebody's gone peacefully is my work, my duty, and I've done this part of my duty, and I find it a most human job. So let's keep igniting more minds, let's keep teaching people around, and this is what your conference is one big part of that. I'm very happy I could really share my experience, although I just sometimes go higher on the modalities, but I really want to give you the extremes, what all can be achieved with our interventions. And until unless you do those difficult interventions, higher interventions, you only then you can include more and more patients and give them relief to those patients. So I know that the pain relief is human right. This has been talked globally, but it's equally our doctor's duty to deliver this human right, and we are doing it for next generations to come, and we are trying to enrich our medical fraternity and medical science in best way possible. Thank you, my friends. Thank you for your time, and I once again congratulate you for doing such a big job, such a nice job, and having me in there. Thank you again, my friends. Bye bye.